tuned into this panel, this session, we'll sort of take a little tour of how data and research, and not like publishing research, but computational work done with data can help us better manage the situation that we all find ourselves in. And we have a spectacular group of presenters. I believe first up, we'll have Tim Souther from Change Healthcare, followed by Debbie Lai from COVID Act Now, then John Church, who will walk us through some interesting analyses on modeled patterns in space and time using IFR, and then Dr. David Pigott from UW Seattle, talking about the impact of modeling and a year of COVID data and how that affects us all now. So the way we're going to run this is we'll have the speakers go through doing quick 5-minute presentations, and then that'll leave us ample time for conversations. And I would like to invite Tim Souther to sort of kick it off and take it away. We got 5 minutes for this first opening statement.
Thank you, Nigam, for that kind introduction. You know, I'm passionate about using data to inform and inspire a better healthcare system. And if we're to do that, we need to better understand patient journeys, yes, clinically, but also non-clinical factors. After all, 99% of life for most of us is spent outside the doctor's office, and social, physical, and behavioral determinants of health influence 80% of our health outcomes. For us, it's the combined clinical and non-clinical patient journey that really matters. So today we're going to look at how those affect COVID outcomes. Let's take a look at the next slide. As many of you know, Change Healthcare is one of the country's most important health IT companies. We're privileged to serve most healthcare constituents in the US. And in doing that, where we're permitted, we de-identify data and then integrate it with major social, physical, and behavioral determinants of health. So we and our partners can work on solving healthcare's toughest problems. So when the pandemic was declared a little over a year ago, we provisioned data pro bono to dozens of academic medical centers, including Stanford, to help the smartest medical minds in our country better understand the pandemic. Their efforts fueled industry dashboards like COVIDcast and the COVID Healthcare Coalition, and their researchers produced provocative insights into telehealth, health inequities, and health policy on things like school reopenings. Right now, there's over 40 active research projects underway addressing the most critical questions about COVID, its impact on the system, disparities in care, intervention effectiveness, and comorbidities. Rather than just talk about this, let me show you why understanding health outcomes through non-clinical factors is so important. Let's take a look at the next slide. Here we calculated the rate of COVID diagnosis, hospitalization, mortality, and vaccine uptake across 4 broad classes of race and ethnicity. You can see diagnosis in the upper left, hospitalization upper right, mortality lower left, vaccination rate in the lower right. Each bundle of columns depicts an index by race and ethnicity over the last year, with 100 marking the average. You can see how the bundles change over time left to right. We're showing just these 4 cohorts, but we can isolate also by country of origin or by language and cultural preferences. The key takeaway here is you can see clear variations above and below average. Some of them are quite significant that just don't show up in clinical data alone. For example, some race and ethnicities like African American and Hispanic over-index in diagnosis, hospitalization, and death, yet under-index in vaccine uptake. Caucasians have a materially different experience, largely the opposite. So it's a sad state of affairs that the color of your skin can definitely influence your COVID experience. On the next slide, I'll show you the same approach that we did for economic stability, doing exactly the same index creation as before, but this time to depict economic vulnerability. Each bundle of columns depicts an index for 9 different levels of economic stability over the last year, again with 100 line marking the average. An upward sloping bundle means an increasing likelihood of occurrence as economic stability declines. You can see that clearly for diagnosis, hospitalization, and mortality. Conversely, a downward slope means increased likelihood of occurrence as economic stability increases, as exists with vaccine uptake. Bottom line here is there's a clear correlation between economic vulnerability and a poor COVID outcome. All right, so what do we make of this? On the next slide, our key takeaway is it's clear that externalities have a significant influence on outcomes. I've shared race and ethnicity and economic stability just now, but these outcomes are also influenced by health literacy, access to care, and health attitudes and behavior. So what do we do about that? We think there are 3 steps that matter. First, it's clear that social, physical, and behavioral determinants of health affect outcomes. So you should know that for your population. And if you need help doing that, we offer a service that can create a customized portrait for your population. Second, it's tempting to be dogmatic, given overwhelming clinical evidence about COVID, particularly regarding prevention and treatment. But we think it's critical to meet people where they're at. Understanding why people do what they do and under what circumstances or barriers are actually discouraging optimal health outcomes. And third, as research evolves, protocols may need to change by incorporating new research findings, particularly those that give consideration to externalities such as those that we've shared this morning. That concludes my remarks, and I'll turn the mic back to Nigam.
All right, thank you, Tim. And just to give a sense of how involved and supportive Change Healthcare was, I've interacted with them in my Stanford role as well as a volunteer for the COVID cast group. And starting all the way from the top to their engineers and the data analysts, we've not heard a no. And for a year, as in giving data pro bono without asking for money, that kind of support from a company is fabulous. And I have no interest in any sort of ever stock interest, anything in Change Healthcare. So I'm not promoting them for business reasons. So thank you, Tim. Next up is Debbie Lai, who is leading another fabulous team called COVID Act Now, which is, I'll let her describe the full journey, but it's about 45 volunteers for the most part who came together in a very short amount of time to put together this dashboard that millions of people use now. So Debbie, walk us through that, please.
Thanks, Nigam. So hi, everyone. I'm Debbie, the COO of COVID Act Now. And prior to the pandemic, most of my team worked in Silicon Valley, and several of the founders and I were actually colleagues at Google. So how did we end up working on COVID data? Back in February, what we saw COVID do was effectively take what used to be the purview of PhDs, MDs, and other public health experts and make all of that everybody's business. And what's more, we saw the disconnect between public health data and the public and the confusion and misinformation that stemmed from that disconnect. And as data nerds, what we wanted to do was make data universally accessible so that anyone, regardless of their background, their expertise, would be able to make data-driven decisions. But it's not just data that I want to talk about today, because here's the thing about data. What is the point of having all that data, all the amazing data, if nobody sees it, understands it, or uses it? What is the point of nerding out on data if it doesn't impact or help anyone? And so what our team knew how to do was how to turn data into billion user consumer products. And that was the expertise we hope to contribute while working closely with public health experts like Nigam on this call. And so with the help of some volunteers across the country, we formed COVID Act Now, developed a nationwide COVID risk level framework, and created data dashboards for all 50 states, some 3,000 counties, 300 metros, and 2 territories. And we went viral in our first week, reaching around 13 million people within 72 hours. And since then, we've served some 2 million people each month across our site, alerts, newsletters, and social channels. And along the way, we've learned some interesting things about how to help the public really connect with health data and information. And in the interest of time and attention spans, I've boiled those learnings down to 5 guiding principles. First, we think about how to make complex information accessible. And the key here is KISS, K-I-I-S, keep it simple, stupid. And let me give an example of that. One of the first things we developed was the COVID risk level framework. And here's the value that we see in frameworks. It takes a lot of complicated and often fragmented bits of information, in this case, case numbers, test positivity rates, and ICU occupancy. And it distills all that information into a simple and easy to understand output, in this instance, a color. red, orange, yellow, green. And that output, that color, immediately tells you what you need to know and how careful you need to be. And our goal was for our data to be so accessible that public health officials and public health makers could use it to communicate with their constituents, which several did, including Governor Cuomo. Second, we want to make data engaging. And I'm not saying that everyone here should go and get a social media account, and I don't have a Twitter, but COVID Act Now does, because we knew how many people were learning about COVID and making decisions during COVID based on what they read there. But it wasn't just about copy pasting our numbers into a tweet. We had to actually know our audience. And on this noisy platform, we knew that visuals, rather than text or number-heavy content, would resonate more. So here you can see an animated map that we created to help people understand how COVID spread. And this was picked up by Forbes, Fast Company, and other press. Most recently, we created a California-specific version of this for TikTok that reached 2.5 million views and counting in 48 hours. Number 3, being organized. So there's so much information data out there that a big piece of our job is just to curate and organize existing information for people. And obviously we did that with data by compiling it from various sources, ranging from federal data sets to private ones to scraping the data ourselves. But we also did that for COVID news and research. We worked with medical students out of Stanford, Brown, Cornell to put together newsletters compiling popular and scientific articles that we had vetted and found relevant for our users. And we now have some 200,000 daily subscribers to those newsletters. 4 is transparency. We'd seen the rampant mistrust that emerged when people didn't feel like they had full visibility into the data and information out there. And so from the very beginning, we've made our model, our data, and even the code for our website open source. We've also designed the site itself so that data sources and methodology is easy to find. And you can see here that for every metric we surface, we clearly show the data source and also the definition. And this is particularly important because in the COVID data space, things are so fragmented that even a seemingly simple metric like test positivity could be defined in multiple ways. 5th, and finally, we aim to be actionable, because what we found was this: if you're able to successfully communicate in an accessible, engaging, organized, and transparent way that reaches people and earns their trust, you've got a lot of power and responsibility. And we saw the data that we were sharing was generating a lot of energy. And without a way to channel that energy, it was leading to frustration and feelings of helplessness. And people like to feel like they have some agency over their lives. So the data alone was not enough. We had to give people ways to act on that data and guidelines for doing so. And that's when we created recommendations, a module for every state, county, and metro dashboard that compiled, organized, and summarized official guidelines for that location, given a particular risk level. And we found that was helpful for people to connect the data they were seeing with actions they could take in their day-to-day lives. And beyond that, we rendered these recommendations as visually engaging modules and gave users another action to take: share the data and recommendations with their friends and family to keep their loved ones safe. And with that, those are our learnings, and I'll turn it back to Nigam Shah.
All right, thank you, Debbie. So next up, we have John Church, who's going to walk us through some fascinating modeling efforts in terms of COVID-19 global mortality.
Hi, my name is John Church. Just following on from what Debbie says, I'm not an expert in epidemiology or virology or anything to do with medicine. And I just started looking at some basic global mortality data back in March and April last year. I'd just like to recognize Raj Bhopal, professor at the Usher Institute at the University of Edinburgh, who came on board with me to further analyze the things that I'd looked at and shepherd me into the sort of world of academia. So I really appreciate how he helped me on this. Next slide, please. So I'm just going to take you through a little bit of the journey that we went on. So the initial thing I was looking at was how exactly is it, that COVID was affecting different age groups and who it was at risk, as many people were, and created a very simple model which evolved over the year. But it was ultimately very simple, quite Eurocentric. But using relative mortality for the UK based on Office of National Statistics data, and the absolute mortality based on the almost perfect experiment of the Diamond Princess, albeit a very small sample size. But it came to the conclusion, as is well known, the tripling of mortality per decade. leading to a very, very wide range in the mortality distribution. And the next step was really to say, well, what would that mean if you applied that across the world, that one model, to look at different countries and see what would the average IFR be for individual nations. Next slide, please. And when you apply that model to all the individual nations of the world, you see that a number of things that come out, but there's a very, very wide range of potential IFR versus the average age across the world. These are the top 40 nations of the world by population, plus a bunch of random other ones which we put in for various reasons. And you can see there's an order of magnitude difference in the actual risk on average in nations all the way from sub-Saharan African nations, which is well less than 0.1%, right up to Western Europe, which is approaching 1%, and the anomalous nation of Japan with its older age. The other thing to notice is that the points all fall relatively closely along a line, as you might expect. The distribution being partly due to variations of how the demographics are within countries, but you can put a line through that pretty well. And make that correlation all the way up. And if you go to the next slide, you can then turn that line into what we called hypothetical mortality, hypothetical lines of the amount of population infected, given a certain number of people that have died. And the whole objective of this was to really try and understand how the epidemic was affecting different regions of the world and different countries once you take the age element out of the equation. Okay, so obviously there's a huge difference between sub-Saharan Africa and Western Europe, but it was really to try and make it transparent what that range was and where different places had been affected in a much more significant way. And the regions of the world are identified there, and the way it's visualized here is as what we call hypothetical lines of population infected. Now that doesn't necessarily mean that's exactly how it is, but it's a way of visualizing. And you can see the wide range of where the worst of the epidemic has occurred. And of course, it's in South America where you see a factor of 2 to 3 worse than Europe. And of course, Europe is a factor of 2 to 3 or more worse than East Asia and even Southeast Asia. And then you can see the southern part of Asia and North Africa and the Middle East all forming a cluster. With a couple of anomalies, Iran and Iraq being a little bit higher. So that was really a way of trying to create a view as to where it was that people were being worse affected than in other places. And it was just a way of visualizing the data, as Debbie said. So if you go to the next slide, just a kind of commentary on this. So the model generated an average IFR variation, which is well over an order of magnitude different, between the range of places I discussed. You get a very wide range of mortality and the spread of infection between different regions. South America is clearly showing 60% plus now. Europe, and that picture was from end of April. Europe and North America are a fairly wide range within those countries, but somewhere in the 20 to 40% range. Sub-Saharan Africans, it's very low, with the exception of South Africa, but it has a much higher age distribution than all the other countries. So there may be something in that, and a very limited infection spread as it's been visualized here in East Asia and Southeast Asia. Of course, the limitations of this, that it's very Eurocentric. It's based on UK Office of National Statistics and the Diamond Princess data, which was populated primarily by Europeans. And of course, the other big issue is there's variable administrative reporting, because multiple countries have now reported that actually the excess death levels were significantly higher than have been reported, and particularly in South America, but it also applies to Russia. That's been reported there, and also in Iran, there is anecdotal stories of that, and also now in India. So if you just go to the final slide, I'd just like to show a sensitivity that I applied where I just added 50% to sort of be in line with those results to countries excluding basically Western Europe, excluding the European Union, North America, and East Asia and Singapore, and everywhere else I added a sort of 50%. And you can see that the spread of how the epidemic has affected different places becomes even wider, because in Eastern Asia and Southeast Asia, adding 50% doesn't do much. But of course, in South America, it spreads it even further to the left. So if you just go back one slide, back to the conclusion again, the final point there is that what we visualize is a hypothetical spread of infection. But of course, it doesn't necessarily have to be that, because there's also the possibility that the IFR itself is very variable regionally, as well as through the age distribution of the peoples of the different nations. And so we need to hopefully use something like this to be able to go further to explain why you get these very regional variations in COVID susceptibility. And that was really all this was trying to do, is to help with the visualization of that.
All right, thank you. So our last sort of panelist speaker is David Pigott from UW. And one of the, probably I would say the leading groups that IHME gets quoted most often in the news in terms of modeling, predictions, projections, and so on. And would love to hear from you on what have you learned in the past year about this modeling of COVID?
Thank you, Dr. Shah. So today I'm going to talk about some stories about data and how data and data errors have been detrimental to us making real-time informed decision-making on how we should be responding and reacting to the COVID pandemic. So next slide, please. Now, obviously, tracking these day-to-day, week-to-week is just an inherently hard problem to do in the first place. In the top left here, we've got a very early bulletin from the WHO from March 2020. And you'll note that there's that day in the middle of February where there were 15,000 new cases reported in one day. And that was a function of case definition changes and using a broader definition of what constitutes COVID. We've seen those kind of issues amplified across the entire world. In the bottom left here, there's a time series from Johns Hopkins University dashboard looking at Montenegro, where prior to late September, the worst day of reporting was a function of a diagnostic backlog being reported rather than anything epidemiological. On the right, I've got a figure here from Mark Bevand, who shows the progression of daily releases of data from the Florida Department of Health, showing deaths being reported. And you'll see that on any given day, you have upwards of a month's worth of backlog of reported deaths being reported at that time. Next slide, please. The other bit, when you're truly thinking global, is what is really the representativeness of the data that you're using to make those global decisions. And I think one area that's really been constrained in terms of global representation is clinical data. And on the left here, I've got a plot showing some of the cumulative all-time ever hospitalized data sets we use, or daily admissions data sets that we use that span the majority of the range of the pandemic. And you'll see that it's really focused within what the World Bank references as the high income countries. And on the right, I've got a couple of insights into how really the publication model really overemphasizes primacy rather than comprehensiveness. So you have disproportionate representation of those countries in these data sets. And in the absence of there being widely available aggregate data that's being made openly available, it's hard to rectify those inequalities. Next slide. I think the final bit that I want to talk about is really how can we account for the effect of non-pharmaceutical interventions and other countermeasures. So on the bottom left here, I've got a figure from Our World in Data showing the Blavatnik School of Government's COVID Stringency Index, which is a composite indicator of 9 or so different factors that track the variety of mandates that have affected our everyday life. But actually, we've seen a real change over time as how they're deployed, from broad, multi-sectoral, fairly binary implementations to now focused, nuanced, both geographically, by business sector, and with a slew of both optional and enforced recommendations. On the top left, in contrast, you'll see for Colorado from a few months ago, a situation where every county is on a separate trajectory with different, with a constellation of different mandates being deployed. On the right, you'll see a figure looking at mobility here, and and I think it calls into question, if we do want globally available data, we have to really think about the representativeness of the people that are included in that data, whether it's by age, by socioeconomic status, or by geography itself. Next slide, please. So what are the solutions to these kind of problems? Well, in the short term, the way that we've been approaching it is to try and triage multiple different data streams, all of which are going to be biased, but hopefully in different ways, and try and come to some sort of consensus trend amongst all of those patterns. So here for Madrid, you've got daily cases, daily admissions, and daily deaths. On the bottom right, you'll see those purple dots that correspond to representative sero surveys that have been undertaken into that community, and we can use all of that information to triage and come to some consensus estimate. And on the final slide, please. We really must think about a sustainable solution going forward. So making data effectiveness and data systems front and center in our response to how we deal with COVID. So, for instance, how can we put data system effectiveness within frameworks like the joint external evaluations? A couple of weeks ago, the WHO and the federal government of Germany launched a new hub for pandemic and epidemic intelligence. What role can they play in bringing together a central global data set that does represent the totality of the populations affected? And finally, in the bottom right, I've got a graphic here from the Ending Pandemics group, which kind of distills our data collection process and pairs it with key performance indices. So not only can we report the numbers that we need, but also some metadata that gives us better insights into how timely or representative those numbers actually are. Thank you.
All right. So thank you to the panelists for this fabulous tour of the various data sources, the challenges in communication, modeling, and then lessons learned across the world, and trying to summarize that for sort of the next time we have to face such a situation. It's not a matter of if, it's probably a matter of when. And one of the things that I'd like to sort of open with while we get questions from the audience is that there's sort of these three interrelated things. There's the data that we have access to, the methods that we apply on them, and then the conclusions or results we communicate to whatever are the stakeholders and the constituents. And there are biases at every step of the way. So in the data, for example, Tim Souther walked us through this associations with skin color that we see in the data, but everybody knows that these are structural inequalities that have been propagated for quite a long time, and there's social determinants of health issues, access issues that appear to be such associations. And then the challenge of communicating them that Debbie walked us through in terms of how do you distill it down so that you have a call to action and to do something. And then lastly, we sort of saw the challenges in drawing global conclusions when their data are predominantly from sort of the rich Western countries, so to speak, and this massive rush to be first and publish something so that we can wave our academic flag and say, I was there first kind of thing. With all of these, next time when we have to do this, how do we educate our own workforces so that we can get it right? I mean, epidemiology and population health has been around before the pandemic came around. It just happens now that all the computer scientists know about epidemiology as a field. How do we keep bridging that so that next time around we're better prepared? And I want to hear from all of you because everyone will have a slightly different take on this. So I see David Pigott raising hands, so let's start there.
I think one of the one of the great examples that we've seen in the US is the work that like COVID tracking has done, not only shining a light on the numbers themselves, but also the provenance of those numbers. And I think one of the bits that's been really great to see from this pandemic is a really broad church of ideas and perspectives coming in to discuss all of these problems. And so how can we normalize that and extend those conversations above and beyond the immediacy of dealing with COVID right now? I think it's going to be the real challenge. Like when we think of data systems, it's not that we don't have good data systems. We just have data systems that maybe had not been prepared for the scope, scale, and timeliness that they've needed to for this specific pathogen. So will there be other pathogens that require that level of attention day in, day out to the extent that I've been spending all my time in 2020 working on? I'm not sure, but we must have a system that's flexible, that it can surge in a way that's warranted when those high profile pathogens do occur.
Right.
I think beyond provenance, or perhaps exploring provenance a bit more specifically, I think the more that you can capture important data as a byproduct of systems that are already in place, that helps to take the friction out of the process. There were numerous examples last year, and perhaps some of the drivers for some of the provenance examples that David highlighted. You know, when you are inconsistently receiving data, it wreaks havoc on any models that you're looking to build out of it. And we saw some circumstances where there were political motivations to that. So we've tried to focus on leveraging regular systems updates and, you know, provisioning off of those. And then it's important to understand the skew of the data itself, and we have humility about it. I mean, you know, our data comes from commercial claims, and that may or may not be representative of the population at large. So we've worked pretty hard to try to normalize that to the US population by examining independent data sources. So those that want to examine race and ethnicity or country of origin or language or economic stability or health literacy, you know, the benchmark isn't the data that we see. It's the benchmark is data about people at large in the United States, and then provisioning tools that allow smart data scientists to normalize with that in mind.
All right, Debbie.
Yeah, the one thing I'd add, Nigam, is in addition to kind of communicating the data to the public, I think it's also important to communicate with each other. And I'll speak mostly to government data, which is what we work with. And, you know, as Tim mentioned, there are certainly times when the data was inconsistent or missing for, you know, maybe reasons that we weren't very happy with. But I think in many cases, you know, that we were working with government departments that were, I think they were hard pressed, and they were kind of, you know, between a rock and a hard place. They can release the data more quickly, but it might be less accurate. They release it and it's more accurate, but more slowly. And so, you know, we understand that they're also just working really hard. And what we found was helpful was just to be in open communication with them. If the data was going to be late by 3 days or 7 days, if they were changing the definitions. And so just having that communication between all the people working on the data was really helpful.
So I'm going to try to weave in a few more questions from the audience, while at the same time, I want to dig a little bit deeper on the issues we brought up here in your responses and what the previous panel sort of ended with, which is trust. So to paraphrase these various data issues, computational people, myself included, we would take bad data if it was available real time. Because, I mean, if you've dealt with web data, you can clean up bad data, but you can't do magic to clean up for a 7-day delay in the data. Whereas the medical establishment, which is like I trained in medicine, the focus is more on being deliberate, accurate, and making sure whatever you say is not wrong. So a few days delay is okay, but you want to make sure what you say is correct. And those two goals are inherently at attention. And communication and trust can definitely solve that. Multiple data streams can solve that. What could be other possible solutions to that? I just see John Church is back with us, and if you had the opportunity to hear the question, I'll probably give you the floor first. What do you see are the ways in which we can bridge the two worlds? Yeah, we can't hear you. You were muted. We could not hear your response.
Sorry, can you repeat the question? Sorry, I've got some ongoing things here, a bit unexpected.
Oh, no, no worries, no worries. Then the question was, how do we bridge the competing needs of the data people, which is, we would want data as soon as possible, as broadly as possible, from the need of making sure that whatever public health data are released are correct. So accuracy versus speed trade-off. Let's just dumb it down to two things.
Well, all I can say is the analysis I've done, the absolute was not so important. It's more the trends and the variations between them. So the work that we did was not so reliant on the exact needing accuracy, and we recognized as one of the main limitations was the fact that even if the data source itself was trying to be very accurate, the input to it was coming from variable sources and was not going to be able to be consistent. And that's why we just did a sensitivity on this to try and understand whether the messaging of the results that we'd come up with led to the same conclusion, which I think they did. But it was only a small example of that, and I don't really have a solution to it. And I just, the most important thing to me was to use the same data source all the time to be consistent.
All right.
But I'm only working with one data set, and it was just an example.
All right. So I'm going to use that as a cue to go into an audience question, which is along the lines of, how do you make sense of bad data? So for example, Anushka Gol is asking, can you speak more about issues you might find with available data, such as death and case rate undercounts in India, and how would you tackle these issues? And I think David Pigott might be able to speak to that, given their global view of the data sets they work with.
So I think this is where this notion of looking at different data sets to be sentinels as to the accuracy or completeness of other data sets. And also the one benefit you can leverage from looking at it globally is you can look for country to country discrepancies and variations to see whether that is actually something that's indicative of a meaningful epidemiological difference, or actually is an artifact entirely from differential data systems responding to the pandemic. So I think the underreporting aspect is really fascinating. I think it's one of the main ways that gets really quantified is actually looking at all-cause mortality, so all the deaths that happen across the entire population. And the only way that you can do that is from a data system that you can't cobble together in the course of a few months, unfortunately. So that's where this kind of preemptive data preparedness and thinking of vital registration systems as a key part of being prepared for not only pandemics, but also just general health care in the future is important. But then also looking at the media, like I think in India in particular, there are a lot of journalists who are actually highlighting, for instance, cemetery records. I'm sure many of you have seen the work that The Economist has done in highlighting some of those earlier studies of showing, well, actually, there seems to be a large disconnect here between the official register of reported deaths and the fact that here we have a cemetery that is several times higher than it's ever been in terms of number of burials a day. So that's kind of how we approach this kind of multiple data streams and looking for conflicts and trying to figure out what is the reason and rationale between those different conflicting numbers.
We did basically the same thing. It's like Reagan telling Gorbachev, trust but verify. We have pretty good confidence in the underlying fidelity of our data, but we, benchmarked it against IHME. We benchmarked it against Hopkins just to, suss out whether or not their conclusions were any different than ours. So it's just, trust but verify against other sources that are trying to make a similar conclusion.
All right. So I'm going to go on to another audience question, but I'm going to preface it with like 10 seconds of commentary. When dealing with data, and the sort of the general theme we've been talking about is this trust but verify. We can have bad data, but put in place procedures in order to either compensate for the high variance that we're getting or the systematic biases that we're getting. And those kinds of tricks work as long as we're focused on trends, differences over time, and the kinds of things. But in public health and in medicine, we often want to get to root cause. And so given that things like socioeconomic status and race and ethnicity are correlated, and we have these messy data, can we even get to analyses about causal predictions or causal associations or attributions as to why something is happening? It's a tough question, and trying to do that with messy data is difficult, but what have you seen in your work of getting to root causes of these issues using the data we have at our disposal?
I'll start. So the first thing is to understand at a root level how skewed the data is or isn't. So we talked about some techniques earlier in our panel on how to do that. And I think the second thing is to make sure that you have enough data that is connected over time, so that as you are making assumptions about how a particular pathway is proceeding, and you are making adjustments to de-skew the data, that you actually have enough data to be able to make a statistically confident projection. So one of the nice things that we've done is we have about 35 billion care events going back to 2012, and they're all isolated to a de-identified patient. So having the ability to understand the circumstances of the cohort that you're looking to study, that's the type of data that we make available to medical researchers so that they can create an accurate initial foundation, and then use that as a basis to make a reasonably accurate prediction.
Yeah, I think the if I just follow on, I think that Nigam, what you stated about the fact that the word trend is what's important. So to me, it was always looking at the broader picture and understanding the big trends of what was going on rather than the exact accuracy. So when the work we did, we looked at regions. The individual countries were not so much of exact interest, but it was the fact that you get this clustering of countries and regions. And it was the anomalies to that which are what really required the explanation. And so the big question is, why is it that these big countries in East Asia have zero impact relatively compared to Europe, and that Europe is 2 to 3 times less than South America on an age-based analysis? Once you take age out of the equation, because looking at the gross level doesn't really help. It's once you take age out of the equation, why is that? And I don't know the answer. I just, but that it was just trying to create that kind of view. So it was the broad trend and the broad picture, rather than worrying exactly how many people have died in Brazil or in Peru or in India.
For me, I think it's important to like you were talking about like building in robustness or flexibility, and like be constantly challenging the paradigm in terms of like, if you're accumulating data in a piecemeal manner, you must be thinking about that new data and how it either complements what you already know or fundamentally challenges what's been stated beforehand. So in particular, looking at those clinical characteristics elements, like actually how representative was the initial experience in Wuhan of the rest of the world's trajectories. And if you're not flexible to those kind of approaches, I think that's when you get entrenched in incorrect assumptions that you then just amplify to a global scale.
Debbie.
So I would draw on something that Tim mentioned before, which is humility. And I think when answering the question of why, which is a very loaded one, I think that's important. And I'll say something that maybe won't be popular for this panel, but I actually think that there are limits to what data can tell us about why. And I think that it does need to be combined with, the human component of the answers to these why questions. And we're not anthropologists, but, at the end of the day, we did feel like to really answer certain questions, we couldn't just look at data. We actually had to talk to, other human beings, which we don't love doing, but sometimes like
yeah, one of the sort of just to build off of that, one of the lessons from basically a year of firefighting with bits and bytes is that depending on the source, you can get whatever the answer you want. And so to build off of Debbie's point, I think there are data streams out there that can give us global scale. You can get 2 indicators that are available for every country with certain fixed biases and errors that you can use for forecasting. Like, I'm simplifying, but by and large, we can do that. And then for a particular town, we can get the detailed data that allow us to do some causal analyses. But the world is somewhere in the middle. And then we also have to communicate where exactly are we on that spectrum from one end to the other. And so where I'm going with this is that if you had your pick of the 5 data sources that magic wand, you could get it for all 180, 190 countries worldwide, what would you wish for? And there's a reason I'm asking this question. Like, as a global health community and as data scientists trying to assist the experts in the global health community, what would be our request to them, saying, if you get us these 5 things, next time we will be able to have better lead times. On that last slide David Pigott showed about the outbreak detection, the response time, and all of those times will be shorter. So we'll go across the whole panel. 5 data indicators, what's on your wish list? So on my screen, David is first, so I'll start there.
I think the one that's been proven to be really important throughout is age stratification. Like John was showing that mortality varies by age. We've also seen hospitalization patterns vary by age. Obviously now vaccination has come in, and that's fundamentally shifted the age structure of deaths and hospitalizations. And then also when you're thinking about the countermeasures you want to deploy, different mandates are fundamentally going to shift things for different age groups. Like obviously the way that school closures are going to manifest is fundamentally different to a restriction that you may put on elder care home access or visiting hours or something like that. And when you're looking at a total number, all of that nuance gets removed, and you aren't able to see how each, like, I think many of us have probably seen those trends in Israel, that as different age groups become eligible for vaccination, you see a corresponding decline in a variety of different metrics.
I think that's a very good point about it's the age stratification, which is almost the heart of where any analysis on the learnings of COVID really should be focused. So trying to really understand what the impact of that was globally and what the impact of that was in terms of response. Did we really use the fact that this is such an age stratified issue to the highest level of advantage? And I'm not sure the answer is positive on that. And because it is an extraordinary stratification, and it's stratified in Europe completely differently from the way it's stratified in other parts of the world. And that's what the work that we try to do to visualize that. What you see in Europe is completely different from what you might expect in other places. And again, the exact numbers don't really matter, but clearly there's big differences.
So Nigam, I don't have 5, but I have 2. And the first one is we've talked a lot about inequity, and I think that inequity exists on multiple dimensions. And so I would actually just love more data on those other dimensions beyond the ones that currently exist, which focus on demographics. And the second one is I would have loved to get more information on the sources of transmission and to have that collected, via contact tracing or whatever other means, so that we can actually have empirically based policies, which I think we agree has not really been happening consistently.
Well, most of the work that I do is US based, so I feel pretty confident about one of those 180 countries that you referenced. So, Debbie, we can help you out on the ethnicity and social determinant side of the equation. But I think broadly, I think we have to think about it. What problem are we looking to solve? If you want to have 1 or 5 perfect data set, that's a function of what problem you're looking to solve. And it feels to me that the whole world was ill prepared to understand as viruses were moving from animals into humans. And all the topics that we've talked about right now are information about humans, but maybe we would be better served by having, earlier visibility to the viruses that exist today in animals, and are monitoring that so that we can have earlier visibility to mobilizing activity to deal with it.
So I'm going to use that as a jumping off point from a lot of audience sort of zeitgeist that Lata just summarized for me. There's sort of 2 things I see missing in the conversation, which the audience has thankfully brought up. One is the molecular data on variants, as in which builds off to the what is going on with the causative agent, and the molecular evolution and sort of the genetic epidemiology data. They do exist, but not systematic and quite patchwork, and not yet connected with the kind of population level modeling that's going on. So that's sort of one vector. And then the other is the immunology side of it. So for example, Dr. Benjamin Pinsky on our grand rounds on Wednesday was talking about how the current vaccines also provide protections against these variants that are being talked about in the media. And as part of a pandemic response, not only need to monitor the evolution of the pathogen, we also need to monitor the relative efficacy or lack thereof of our defense mechanism. I mean, a mask is still going to work against all variants. I mean, it's a physical device, so it doesn't matter. But a vaccine triggers an antibody, which, now it's good, it's working, but it may not work against certain variants. So far, so good. So those are the 2 data streams. What's going on with the virus, and how good or effective are our defenses? And what are your thoughts on the panel in terms of getting those inputs in to the consciousness of our data community in a way that we can be helpful to the public health professionals? I mean, these are people who do this for a living. About 50,000 or 100,000 data people jumped in saying, let us help. But we're helping a profession that already comes with a decade of training. So humility and communication goes a long way in that situation. So what would be your thoughts on combining these 2 inputs in the current work that is going on that you're all aware of? And again, I'll start with David, and we'll just go down the roster.
Yeah, I think specific countries in particular have really demonstrated the role that genomic epidemiology can play. So the UK is a standout example of a nation that has been able to effectively deploy that sequencing at scale, and as a consequence has been able to identify variants, and more importantly, and I think this is the real bit that's going to matter going forward, do it in a way that is getting more representative of the population. So not just being myopic in terms of focusing on importation events or oversampling in a specific cluster, but actually integrating it into routine mechanisms as opposed to reactive mechanisms. And then the other bit is their ability to pair it with subsequent downstream data systems. So it's one thing to figure out whether a virus taken from an individual was of variant X or Y, but it's another to figure out actually for their entire clinical progression, what is the implication of that variant as opposed to a different variant. And so being able to nest that within the entire pipeline, so we can figure out that actually hospitalizations are a lot more severe with this variant as compared to a baseline or a different variant, or mortality is more likely, or the age pattern has fundamentally shifted, that younger, it's more severe in younger age groups. Things like that will really be, from my perspective, like the really transformative potential of those data streams.
All right. Well, next up, we'll go to Tim.
Yeah, it's a question that researchers, I said there's dozens of them active today. That's exactly the question that researchers are asking right now. And the missing piece in the data set that we make available is the particular variant observation. We are working on ways to collect that information. And I think we have to be honest here. It isn't a question of whether we need to do this or how long. It's, you have the manufacturers of the vaccines who publicly stated that booster shots are going to be required. So are they going to be 6 months from now, 9 months from now? Well, that's why you do research. So, we're actively looking at how to go capture variant information, which would come in a lab test and connect it to vaccine information and the social determinants of health and race and ethnicity that we already have. So it's inevitable that this is going to happen.
All right, I think I have Debbie next on my grid.
I don't have too much to add. Similarly, we're working on it. It's important. We need to do it.
All right, and John, you get the last word.
Well, I was sorry, I was in and out a little bit at the beginning, a bit chaotic here, but all I would say is that the visualization, the creation of images and insights from data needs to lead to questions as to why things are the way they are, and it should be a starting point for the next piece of work to try and understand why it is that certain things are different in certain places. And then that's in our specific case, the work we did was just to demonstrate there are obviously differences. And if you don't know why, then you're at some sort of fundamental starting point hasn't been overcome yet. Why is there an age stratification? Why is it that certain parts of the world are affected worse than other parts of the world? And until you know that, then everything else is sort of making it up.
All right. So we're at 10. And I think sort of the 3 bullet points we brought up in terms of data: humility, stratification, and having better insight into the pathogen as well as our immunological responses. Like those would be sort of the 3 macro things on our list. And we're up at a 15-minute break. So thank you for being here. And we'll, after this at 10:15, we'll reconvene for the second keynote by Professor Karim Lakhani from the Harvard Business School, who'll present on the Moderna vaccine case study key takeaways. So thank you for being here. Walk around, take a stretch, and see you back in 15 minutes.